Finding Your Way with Ocular Melanoma. Join me, host Tara McCannell, as I share with you everything I know about ocular melanoma. I hope you will learn, get your questions answered, and be inspired to motivate yourself to empower your own healing. Please visit my resource page, sayhart.com/ocular melanoma. That's SEYHART.com/ocular melanoma for more content and support. There you will find access to my handbook for patients and families, past recordings of episodes of this podcast, as well as recordings of live webinars that I've done over the past year on relevant topics such as a holistic approach to ocular melanoma, a mindset for cancer survival, everything you need to know to help keep the best vision. Please sign up. I will be doing more of these educational sessions in the future. To help spread the word, please share with people you know who may be experiencing ocular melanoma. Find me, subscribe, rate me, because that way more people who are looking for information will find this resource more easily. Today, I'd like to talk about a topic that has come up frequently in ocular melanoma: retinal detachment and ocular melanoma. Why is this relevant? It's relevant because almost every ocular melanoma at the time of diagnosis is associated with some retinal detachment. Let's talk about retinal detachment in general. Outside of the setting of ocular melanoma, retinal detachment is a common ocular emergency that is seen by vitreoretinal surgeons. A retinal detachment is an emergency because you have to have a procedure to get the retina back in order for your eye to see. Untreated, the typical garden variety retinal detachment can lead to vision loss and even blindness if the disease progresses without proper intervention. How does a regular garden variety retinal detachment occur? Remember, this is not the same as a retinal detachment associated with ocular melanoma. So the garden variety retinal detachment is relatively uncommon, but most of us have heard of retinal detachment as a possible emergency that can happen in the eye, and many of us may know of a person who has had a retinal detachment and required surgery in order to reattach and fix the retina to help save the vision. How does a retinal detachment occur? The most common reason that a person develops a retinal detachment is literally out of the blue. There is no trauma, there is no sudden action that makes this happen. A retinal detachment often happens when a person is just sitting, not really doing anything in particular, and they suddenly notice floaters, flashes, the vision starts to decrease. Some people notice a curtain either coming down, blocking their vision, coming up, blocking their vision, or even just a blur that comes in from the side and doesn't go away. When this happens, most people will seek care, they'll see their eye care provider, and be eventually referred to a retinal surgeon to confirm the diagnosis and to perform emergent intervention to save the eye, to fix the retina, to get it back, and hopefully improve the vision. These garden variety retinal detachments happen as we get older. The majority of retinal detachments happen in people who are in their 50s or 60s and 70s. The garden variety retinal detachment can also happen after a person has a cataract surgery. Is it because of the cataract surgery? No. But oftentimes, when people have cataract surgery, there are slight changes in the eye that would normally happen otherwise, and a person may get a retinal detachment. This is very rare, however, but as a retinal surgeon, we do see retinal detachment happening later, sometimes a year after cataract surgery. So we need to be aware of what can happen after procedures, just being aware of symptoms, and what exactly happens in the eye in a garden variety retinal detachment. The retina doesn't just decide to fall off. What happens is that the vitreous humor, this is the substance that fills the eyeball that we're born with. As we go through life, it liquefies and it becomes more and more watery. Hence, sometimes people notice some floaters. It becomes more and more watery, and at some point, there is so much liquid that it suddenly moves down and away from the retina because normally it fills the space of the eyeball, and when it liquefies, gravity tends to pull sections down. And there are very small microscopic attachments of the vitreous to the retina, which lines the inner side of the eyeball. When the vitreous humor suddenly pulls away, there can be the attachments of the retina that result in pulling of the retina, and then a little rip happens in the retina. And when this rip happens, the retina gets torn, and fluid, all this liquefied fluid that's filling the vitreous cavity, the eyeball space, can go under the tear. It can get under the retina because now there's a tear, and slowly this fluid getting under the retina lifts off the retina, kind of like wallpaper peeling off because of a leak. And eventually, this lifting up of the retina will move and lift off the retina until a person notices that there's something wrong with my vision, whether it's blurriness or noticing a shadow, because the part of the retina that's detached doesn't see well. It doesn't see black, but it gets blurry and the vision drops. So a person might notice that if there's like a shadow obstructing their vision, they can sort of see through it, but not clearly like normally. So that's how garden variety retinal detachment happens. And there are a lot of variations. For example, people who are very nearsighted might be at slightly higher risk or tend to get retinal detachments earlier. Certainly, if somebody is in experiencing ocular trauma, like a punch to the eye, you can deform the eyeball all of a sudden and cause the vitreous to pull and rip the retina because of that type of trauma. And then the retinal detachment happens after the retina is torn. So the garden variety of retinal detachment is what we consider one of the ocular emergencies. So if you are ever visiting your eye care provider and you're concerned about new floaters or flashes, your eye care provider is going to want to immediately send you to a retina surgeon to make sure that you don't have a retinal detachment, to check if you have a retinal tear that needs to be treated so it doesn't develop into a retinal detachment, or if you have a retinal detachment, you need to get that fixed. So sometimes when a person with ocular melanoma is in the process of figuring out what's going on, you're getting your diagnosis, you're seeing multiple eye care providers, it often comes up that someone thought that you had a retinal detachment. My doctor thought there was retinal detachment, so I went to see a retina specialist, and it turned out that it wasn't a retinal detachment, but it was a melanoma instead. I've often wondered why would we mix these things up because they're very different. But many times when you have these photographs where you put your face in that big white box to take the picture, the coloration of a retinal detachment and a melanoma can look similar. You see a dark dome-shaped blob somewhere in the vision. And so a person who is less experienced with retinal disease, for example, an optometrist or maybe another eye care provider who doesn't see a lot of retinal disease, may automatically think that the melanoma is actually a retinal detachment and send you to a retinal surgeon. So fortunately, you're going to end up at a retinal surgeon anyway, whether they think it's a tumor or a retinal detachment or a problem with the retina. Thankfully, you're going to see a retina surgeon or a retina specialist, and that is the person who usually is able to make the diagnosis or to have enough suspicion to send you quickly to an ocular oncologist to sort everything out and get your treatment. I want to switch gears a little bit to retinal detachment and ocular melanoma. The difference between retinal detachment with a tumor and this garden variety retinal detachment that I spoke about is that the retinal detachment from a melanoma comes from actively leaking tumor cells. In a melanoma, in any type of cancerous growth, you have cells that are hyperactive. They're rapidly dividing, they're rapidly growing their blood supply. They're totally abnormal and doing things messing up the eye. One of those things, when things are actively growing, is that the vessels that are feeding it are leaky, and you get what's called exudation. Exudation means fluid leaking out of vessels. So as a melanoma grows, the vessels of the tumor leak fluid. And so this fluid has to go somewhere. So it tends to fill the space near the melanoma, which is underneath the retina. So you get this leaking exudative fluid that pushes off the retina in an eye with a melanoma. So sometimes you can have a rather extensive retinal detachment together with your ocular melanoma. And it may look like a garden variety retinal detachment, but in actuality, it is a retinal detachment secondary to an ocular melanoma. There is no tear in the retina. There is no vitreous that tore the retina to make the retinal detachment. It is because the reason is there is a melanoma, there's a cancer that's growing rapidly in the eye, and that is resulting in a secondary, what we call exudative or serous, which is the fluid leaking retinal detachment. And retinal detachment does make us concerned because most of us, when we hear the word retinal detachment, we think, oh my gosh, that's another problem. That's an emergency. I have to get that addressed. But the majority of time, when a melanoma is treated and the tumor is killed, all those rapidly growing tissues are also killed. And so everything stops, the growth stops, and the eye can reabsorb that fluid under the retina. So destroying, killing a melanoma often results in resolution and secondary healing of that retinal detachment. This happens most often when the melanoma is on the smaller side. However, if the melanoma is on the bigger side, in general, the bigger the tumor, the more retinal detachment that exudes from the tumor. If you have a very tiny melanoma, you might see a little bit of retinal detachment on the scans in some of the pictures, which you might not appreciate if you go and look at the eye and examine the patient. But the bigger the tumor, the more retinal detachment that can leak out from it. And sometimes this retinal detachment can be a problem. If after you've had your melanoma treated, and the retinal detachment resolves, there's really nothing you need to do. However, sometimes when people have the melanoma treated, you can get a secondary exudation of fluid under the retina. So, what do I mean by this? Sometimes, if the melanoma is on the larger side, as it's killed and as it's gotten the radiation and it's dying, there can be a lot of inflammation and tissues exuding fluid just because there's death and destruction of this cancerous growth. And sometimes this can cause a secondary retinal detachment. So instead of the retinal detachment going away as the eye heals, we sometimes see just a huge increase in the amount of retinal detachment as the tumor is dying. And sometimes we see this when people have stronger doses of radiation or if the radiation is applied in a different way. For example, large melanomas that are treated with proton beam therapy may often have more exudation than melanomas treated with plaque brachytherapy. We don't have data comparing retinal detachment in these different modalities of treatment, but there's some theories that if you deliver the radiation in a slow, steady rate, you may have less of this reactionary retinal detachment. If you deliver the radiation in a very short interval, say over 3 days, and the radiation rate of release to kill the tumor is very high, this may increase the amount of this sort of reactionary retinal detachment that can happen. Either way, if you are one of those people who have leftover retinal detachment after your melanoma has been killed and you're wondering if there's anything that can be done about it, I would say usually there is. If your vision potential is pretty good and you saw pretty well before you had the treatment, and now your vision has dropped, and it seems like your ocular oncologist feels that the drop in vision is related to retinal detachment, if your retinal detachment is not getting better, that can be repaired. Many times in ocular oncology, we may not reach out and utilize tools that retinal surgeons can use to fix retinas. As a retinal surgeon, I know that there are many instances where sometimes people just leave the retinal detachment after melanoma is treated because they don't think that anything is going to help the patient. If you have been told that your decrease in vision is due to leftover retinal detachment and it's been a few weeks after and nothing seems to be improving, I would encourage you to ask about options to do surgery on your eye by a retinal surgeon so that that retinal detachment can be healed. I've heard some ocular oncologists put patients on steroids or other medications to try to reduce the inflammation and lower the retinal detachment. But adding steroids when there's a lot of retinal detachment usually doesn't make much of a difference. So I want to put this information out there so that you may better understand the difference in retinal detachments, the garden variety type that people who don't have melanoma have and that are much more common, and then retinal detachment that's associated with leaking vessels that is secondary from a cancerous tumor that's growing in the eye. And also to understand that there may be ways of treating retinal detachment in an eye, even if there's a melanoma in the picture. So many times we just take we just take what our doctors have told us as there's nothing else that can be done. But I encourage you to ask questions. Say, why is my vision decreased? If you say that there's retinal detachment, can that be fixed? Is it ever going to go away? What's happening and what's the plan? Because sometimes even the ocular oncologist might not have it in their mind that this is something that can be fixed. Because I'm aware of many ocular oncologists who just watch retinal detachments rather than treating them. So it's at least worth your effort to ask your ocular oncologist what is going on in your eye, what are the options, what can be done. Because most ocular oncologists do not do retinal surgery, they may not have at the top of their mind to refer you to a surgeon who may be able to fix the situation. And I do know there are many retinal surgeons who are not very comfortable operating on eyes that have been treated with the melanoma. But there are many of us who do, so I encourage you to ask your doctors, ask your healthcare team what options are potentially available to you. I hope this has been helpful. Thank you so much for listening.